1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, start of
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Usually when we talk about a medical diagnosis, there's this expectation of precision. It feels a bit like engineering.
Right. It's very binary.
Yeah, exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is.
It's comforting, really. The pathology is visible, it's easily categorized, and the treatment protocol is just a straight line.
But then you step into the world of neurodevelopment, trauma, and psychiatric nursing, and suddenly that x-ray machine is just, well, it's broken.
Completely useless.
Yeah. We're looking at a diagnostic landscape that is entirely murky. It's this world of invisible chemical storms. And today, we are mapping those storms. We've taken a stack of your core psychiatric nursing textbook chapters, the clinical guidelines, and our mission for this deep dive is to extract the absolute highest yield neurobiology and psychopharmacology.
Because we're not here to just read a syllabus at you.
No, absolutely not. This is custom tailored for you, the nursing student, the clinical practitioner. We're treating this as an elite psychiatric nursing review session. We want to give you the clinical judgment you need for safe patient care and to absolutely crush the NCLEX.
And to achieve that, we are completely throwing out the traditional, passive lecture format. We're going to break this complex material down using a strict clinical nursing model.
Which means we're focusing on the pathophysiology, the expected findings, the medications, the priority interventions, and this is the big one, the safety red flags.
Right, because on the floor, recognizing those red flags is literally the difference between a near miss and a fatal outcome.
Okay, so let's unpack this, starting with the physical brain itself and the chemicals that run it. Because, before we even touch a medication vial, we have to understand the environment those drugs are acting upon, right?
Exactly. The physical brain structures and the neurotransmitters are the foundation of every single psychiatric nursing intervention. They form the entire rationale for our clinical assessments.
So where do we start? The cerebrum.
Yeah, specifically the frontal lobes. That is your patient's command center. It handles the organization of thought, voluntary body movement, moral behavior, executive decision-making.
Okay.
So when you assess a patient with schizophrenia or, say, ADHD, and you see this profound disorganization or impulsivity,
you're actually witnessing abnormalities in that specific frontal lobe pathophysiology.
Exactly.
That it makes so much sense. It explains why executive function is so compromised.
Yeah.
But then you have the limbic system sitting just above the brainstem, right? Like the thalamus, hypothalamus, hippocampus,
right.
amygdala.
Right, the emotional engine.
Yeah, if the frontal lobe is the command center, the limbic system is the engine. It regulates memory, emotional arousal, the fight or flight response. So if a patient is exhibiting violently poorly controlled emotions or that profound memory loss we see in dementia.
The disturbance is localized right there.
Yeah.
But, those physical structures are really only half the story. The real action, the target of all our pharmacology, happens in the microscopic communication between the cells.
Which is driven by neurotransmitters.
Right. And there are 4 major chemical messengers you absolutely must master. First is dopamine.
The big one.
Yeah, the big one. It's an excitatory neurotransmitter involved in complex movements, motivation, cognition. The clinical takeaway here is that excess dopamine is heavily implicated in schizophrenia and acute psychosis.
Okay, got it. Then we have serotonin, which is primarily an inhibitory neurotransmitter, right?
Yes. It regulates food intake, sleep, temperature, mood. So a deficit here plays a massive role in anxiety and depression.
Okay. And then norepinephrine.
Also an excitatory chemical. It controls attention, learning, systemic arousal, and finally GABA, or gamma-aminobutyric acid.
GABA is the brakes, basically.
Exactly. It's the brain's major inhibitory neurotransmitter. It modulates and calms hyperactive neuronal firing.
So to understand how our nursing interventions manipulate these chemicals, we really have to look closely at the synapse, like that microscopic gap between the neurons.
Me too.
And I want to move away from the basic textbook analogies here because I think they kind of oversimplify what the nurse actually needs to know. Let's think of the synapse as a river.
Okay, I like that.
The neurotransmitters are the water flowing from one neuron across the gap to the receptors on the other side. But the water can't just flow endlessly and flood the valley. What actually happens to clear that chemical out so the nerve can reset?
That's a great visualization because the body has two primary drainage systems to prevent that flooding. So after the neurotransmitter relays its message, it's either transported back into the original neuron to be stored for later.
Which is reuptake.
Right, a process called reuptake. Or it's actively metabolized and destroyed right there in the synaptic space by specific enzymes.
Like MAO.
Exactly, monoamine oxidase. Understanding those two mechanisms, reuptake and enzymatic breakdown, is the entire foundation for how our major psychiatric medications function.
Okay, so pharmaceutically, we are either building a chemical dam to block the reuptake, forcing the neurotransmitter to pool in the synapse, or we are neutralizing the enzymes that are trying to destroy it.
That's it. Either way, the clinical goal is to artificially maintain higher levels of that chemical in the gap.
Wow. And if we connect this to the bigger picture, we aren't just theorizing about these chemical pools anymore, are we?
No, not at all. Modern brain imaging techniques like CT, MRI, PET, and SPECT, they allow us to correlate these chemical imbalances with structural changes in living patients.
Like what?
Well, for instance, CT scans reveal that some patients with chronic schizophrenia have significantly enlarged ventricles in the brain.
Really?
Yeah, and that structural change is directly associated with marked negative symptoms like flat affect and just a much poorer overall clinical prognosis.
Okay, so we've established how dopamine naturally flows, but what happens when we intentionally disrupt that flow? Which brings us to antipsychotic medications.
Right, the drug's designed to aggressively block dopamine receptors.
Let's get into it.
So, antipsychotics are the primary medical treatment for schizophrenia, acute mania, psychotic depression. Their major mechanism of action is blocking those D2 dopamine receptors. But, and this is a massive distinction you need to make for your clinical practice, first-generation conventional antipsychotics like haloperidol.
Hold on.
Yeah, Haldol. They are highly potent D2 blockers. They are incredibly effective at stopping active psychosis.
But there's a catch.
A big one. Because they indiscriminately block dopamine in the midbrain's basal ganglia, which coordinates movement, they cause severe, sometimes dangerous movement side effects.
Which is why the field shifted towards second and third generation atypical antipsychotics, right?
Yeah.
Like clozapine, risperidone, aripiprazole.
Exactly. They are much weaker D2 blockers, and they also inhibit serotonin reuptake. By targeting both systems, they treat the active psychosis with far fewer movement side effects, while simultaneously addressing the negative depressive symptoms.
But the clinical danger still heavily surrounds those movement side effects, especially with the first generation drugs.
Oh, absolutely. These are known as extrapyramidal symptoms, or EPS, and recognizing them instantly is a core nursing competency. The most acute is dystonia.
And that looks like what exactly?
It manifests as severe involuntary muscle cramping and rigidity. You might see a patient with a stiff, thick tongue causing airway concern, a painfully twisted neck known as torticollis, or their eyes involuntarily rolling back in their head.
That sounds terrifying.
It is physically agonizing and terrifying for the patient.
Okay, so if I see a patient presenting with torticollis after receiving haloperidol, my priority nursing intervention has to be immediate. I'm not calling the provider to wait for an oral medication to kick in.
No, you don't have time for that.
I'm administering an intramuscular anticholinergic, like benztropine, that's Cogentin, or diphenhydramine. But wait, why do anticholinergics work so fast to fix a dopamine problem?
Because motor control relies on a really delicate balance between dopamine and acetylcholine. When the antipsychotic aggressively crushes the dopamine levels, acetylcholine becomes relatively hyperactive, and that causes those severe muscle spasms. Ah, okay.
So giving the anticholinergic blocks that excess acetylcholine, rapidly restoring the balance and stopping the dystonia.
That makes perfect sense. Now, another EPS is pseudoparkinsonism, which visually mimics Parkinson's disease, right? So a shuffling gait, mask-like facial expression, drooling, cogwheel rigidity.
Yes, exactly.
But I want to focus on akathisia because I think it's the trickiest one for nurses to assess. If I have a psychiatric patient pacing the halls up and down, looking incredibly agitated, how do I differentiate between akathisia as a medication side effect versus just severe, uncontrolled anxiety from their underlying disease?
It's one of the most frequently tested concepts because the intervention relies entirely on your assessment. So a patient with akathisia will report an intense, unrelenting internal drive to move. but visually you will notice a rigid posture, a mechanical gait, and a distinct lack of spontaneous natural gestures.
So it looks driven but robotic.
Exactly. And if you misdiagnose that mechanical restlessness as standard anxiety, your instinct might be to administer more antipsychotic medication to calm them down, which would be disastrous.
Right, it's like pouring gasoline on the fire. It will make the akathisia significantly worse.
A completely mechanical restlessness. I'll definitely keep that in mind. Okay, let's look at the long-term red flags, specifically tardive dyskinesia, or TD. This involves involuntary movements, like constant lip smacking, tongue thrusting, or excessive eye blinking.
Right. And the terrifying aspect of TD is that once it fully develops, it is generally irreversible.
Wow.
So the priority nursing action isn't a cure, it's prevention and early detection using standardized monitoring like the Abnormal Involuntary Movement Scale, or AIMS.
Got it. And we absolutely must discuss the most critical life-threatening complication of these medications, neuroleptic malignant syndrome, or NMS.
Yes. NMS is a fatal, idiosyncratic, toxic reaction. The classic clinical triad you're looking for is a sudden high fever, severe lead pipe muscle rigidity, and profound autonomic instability, meaning wild blood pressure fluctuations, tachycardia, and excessive sweating. NMS is an absolute medical emergency.
So the moment I assess that triad, my first nursing intervention is stopping all antipsychotic medications immediately. I'm not waiting for lab results.
No. We stop the offending agent and initiate supportive care to manage the hyperthermia and dehydration.
Okay, let's shift to a highly specific safety warning regarding the atypical antipsychotic Clozapine. While it's incredibly effective for treatment-resistant schizophrenia, it carries a potentially fatal risk of granulocytosis.
Right. The drug essentially suppresses the bone marrow, causing a severe drop in white blood cells. This leaves the patient entirely defenseless against infection.
Because the immune system is wiped out, the patient will suddenly develop a fever, profound malaise, a sore throat. That means the priority nursing assessment when a patient is on Clozapine is strict, mandatory monitoring of their white blood cell count, and absolute neutrophil count, or ANC.
Weekly for the first 6 months. No blood draw, no medication, period.
Period. And we also need to highlight a crucial black box warning for all atypical antipsychotics. They are associated with a significantly increased mortality rate in elderly clients suffering from dementia-related psychosis.
Yeah, the deaths are largely attributed to cardiovascular events or infections, so utilizing these drugs in that vulnerable population requires extreme caution and just constant monitoring.
Okay, let's move away from dopamine blockade and look at medications that cause serotonin and norepinephrine to pool in the synapse. Antidepressants.
We're dealing with 3 main classes here. The selective serotonin reuptake inhibitors, or SSRIs, like fluoxetine and sertraline, the older tricyclic antidepressants, the TCAs, and the monoamine oxidase inhibitors, the MAOIs.
And they all function by either acting as that chemical dam to block reuptake or by neutralizing the MAO enzymes.
Right, but the clinical danger with antidepressants isn't just their mechanism, it's their timeline. These medications take significant time to achieve full clinical efficacy. TCAs can take 4 to 6 weeks, SSRIs take 2 to 3 weeks.
And that delayed onset of action creates one of the highest risk, most heavily tested safety windows in all of psychiatric nursing.
It does.
Because here's where it gets really interesting and, well, incredibly sobering. It's the suicide paradox. Why would a medication specifically designed to treat depression suddenly make a patient more capable of carrying out a suicide plan?
It comes down to the physiological timeline of the body's response to the drug. When a patient is suffering from severe major depression, they often present with profound psychomotor retardation.
Right, they're physically exhausted.
Exactly. The body is essentially powered down. They physically lack the energy to get out of bed, let alone act on suicidal ideation. When you initiate an antidepressant, the systemic energy and motivation return within days as those chemical levels rise. However, the neural receptors take weeks to fully adapt and actually lift the psychological hopelessness.
So that means during weeks 2 through 4 of treatment, the patient finds themselves in this terrifying window. They are still profoundly depressed and hopeless, but they now possess the physical energy and cognitive organization to successfully carry out a lethal plan.
Precisely. Therefore, the absolute priority nursing assessment during the initiation of any antidepressant is unrelenting, direct suicide risk monitoring. And this is exactly why SSRIs are the first-line preference for high-risk patients. Unlike TCAs and MAOIs, SSRIs have a much wider margin of safety and are generally not lethal in an intentional overdose.
Okay, let's talk about MAOIs really quick.
Yeah.
If I'm discharging a patient on phenelzine, I know I need to warn them about their diet, but memorizing a random list of restricted foods is tough. Is there a physiological common thread linking aged cheese, tap beer, and cured meats that makes them so dangerous?
Yes, there is. The common thread is tyramine. The MAO enzyme that the drug neutralizes is the exact same enzyme responsible for breaking down tyramine in the gut.
Ah.
So if you inhibit that enzyme and then consume foods rich in tyramine like mature cheeses, salami, sauerkraut, or microbrewery beer, the tyramine enters the bloodstream and acts as a false neurotransmitter. It physically displaces norepinephrine from the nerve terminals, causing a massive, uncontrolled sympathetic nervous system surge.
Which results in a life-threatening hypertensive crisis. So patient teaching is priority number one. If a patient on an MAOI eats a pepperoni pizza with extra cheese, they aren't just risking an upset stomach. They are risking severe hypertension, hyperpyrexia, tachycardia, and a potential hemorrhagic stroke.
Absolutely. And we also must monitor for serotonin syndrome, which is a potentially fatal interaction that occurs if you mix an MAOI with an SSRI, causing catastrophic serotonin overload.
Symptoms being severe agitation, hyperreflexia, fever, sweating.
Yes. You must ensure one class of medication is completely washed out of the patient's system before initiating the other.
Okay, let's transition from lifting severe depression to capping the extreme fluctuations of bipolar disorder. We're looking at mood stabilizers, and the gold standard is lithium.
Right. And the foundational NCLEX logic you need to sear into your brain is that lithium has a dangerously narrow therapeutic index. The target serum level is roughly 1.0 NEQL. Anything over 1.5 is considered toxic.
And understands the why behind that toxicity is vital. Lithium is a salt, and it directly competes with sodium in the body. So if a patient becomes dehydrated or loses sodium through excessive sweating, the kidneys will reabsorb lithium in its place, rapidly driving serum levels into the toxic range.
Exactly. And the earliest red flags of lithium toxicity are severe diarrhea, vomiting, drowsiness, and generalized muscle weakness.
So if I assess those signs, my priority action is clear. Withhold the next dose immediately and draw blood for a serum lithium level. If that level exceeds 3.0, the toxicity is so severe, the patient may require emergency dialysis to clear the drug.
Yep. We also utilize certain anticonvulsants off-label as mood stabilizers like valproic acid, carbamazepine, and lamotrigine, but they carry incredibly severe systemic red flags.
Let's hear them.
Lamotrigine is notorious for causing Stevens-Johnson syndrome, which is a rare but life-threatening hypersensitivity rash that causes the epidermis to separate.
Ouch.
Yeah. Valproic acid carries serious risks for fatal hepatic failure and acute pancreatitis. And carbamazepine can suppress the bone marrow, leading to aplastic anemia and a granulocytosis. Baseline and continuous laboratory monitoring for liver function and blood counts is absolutely non-negotiable.
Okay, so the text mentions the kindling process regarding how anticonvulsants work for bipolar disorder, and I keep picturing an electrical feedback loop in a microphone. You know, tiny sound goes in, gets amplified, feeds back, and suddenly you have this deafening screech. Does the brain do something similar?
That is a perfect visualization.
Yeah.
In the brain, a minor unmedicated mood swing acts like that initial sound. If it isn't stopped, it creates a neurological feedback loop, gaining momentum and lowering the threshold for the next episode until it erupts into a full-blown manic avalanche.
So the medications...
The anticonvulsant medications act as the circuit breaker. They raise the neuronal threshold, stopping the electrical feedback loop early before the mania can take hold.
Makes sense.
What's really fascinating here is that while we understand how anticonvulsants work, lithium, our oldest and most effective mood stabilizer, still holds neurobiologic mysteries.
Really?
Yeah. Unlike other drugs that simply block receptors in the synapse, lithium alters intracellular signaling, interacting directly with G proteins and secondary enzyme subsystems. We know the exact serum level that keeps patients safe, but the precise cellular magic stabilizing their mood remains incredibly complex.
Wow. Okay. Let's move to the extremes of central nervous system activity. Psychiatric emergencies, anxiolytics, and stimulants. Starting with the profound suppression caused by benzodiazepines.
Right. Anxiolytics like diazepam or lorazepam are powerful GABA agonists. They heavily promote that inhibitory neurotransmitter, aggressively calming the CNS. But because they alter the baseline chemistry so deeply, they cause severe physical dependence.
Meaning abrupt withdrawal can trigger fatal rebound seizures.
Yes. The primary nursing priority is ensuring these medications are tapered gradually under strict medical supervision.
They also have a dangerous synergistic effect with alcohol, right?
Yeah.
Because both are CNS depressants. One drink on a benzodiazepine physiologically acts like 3.
Exactly. The resulting respiratory depression can be fatal, and in the elderly population, it creates a massive prioritizing fall risk.
And on the absolute opposite end of the spectrum, we have stimulants such as methylphenidate or amphetamines prescribed for ADHD.
Right.
I always found the clinical logic here kind of paradoxical. If I have a hyperactive, impulsive child bouncing off the walls, administering a powerful central nervous system stimulant seems counterintuitive. Why doesn't it make the hyperactivity worse?
It's because of where the stimulant acts. These medications trigger a massive release of dopamine and norepinephrine, but they specifically stimulate the inhibitory centers of the frontal lobe. Yeah, they are essentially powering up the child's underdeveloped neurological braking system, giving them the chemical bandwidth to filter out external distractions and internally manage their own behavior.
That makes patient teaching critical, though. Because these drugs speed up metabolism, they frequently cause severe appetite suppression and weight loss.
Very common. Providers often recommend drug holidays on weekends or during the summer to allow the child to catch up on normal growth.
And the ultimate safety warning for parents: keep these locked up. Just a 10-day supply could be fatal in an accidental pediatric overdose.
It's so important. We also need to cover disulfiram, or antibuse, which is used as a deterrent in alcohol use disorder. It fundamentally alters how the liver metabolizes alcohol by inhibiting aldehyde dehydrogenase.
So if a patient consumes even a drop of alcohol while taking it,
Toxic acetaldehyde builds up instantly, causing violent throbbing headaches, severe hypotension, nausea, and potentially fatal cardiovascular collapse.
the patient education here goes way beyond just, avoiding cocktails. They must obsessively read labels. Hidden alcohol in everyday products like mouthwash, aftershave, over-the-counter cough syrup, it will trigger that exact same violent reaction.
Yes, and the absolute clinical red flag: never, under any circumstances, administer disulfiram to a patient who is currently intoxicated.
Got it. I also want to touch on patients trying to bypass the pharmacy altogether. What are the specific red flags if a patient attempts to treat their depression or anxiety with over-the-counter herbal supplements?
It's a massive blind spot in patient safety. Herbal medicines are chemically complex, biologically active, and entirely unregulated.
Like St. John's wort.
Exactly. It's widely used for depression, but it behaves similarly to an SSRI. If a patient combines it with a prescribed antidepressant, they can easily trigger fatal serotonin syndrome.
And supplements like kava and valerian.
They naturally depress the CNS. If combined with a prescribed benzodiazepine, it leads to compounded severe respiratory depression. You must explicitly ask about herbal supplements during every admission assessment.
Okay, let's put this clinical logic to the test. To fulfill the specific mission of this deep dive, we are synthesizing everything into the ultimate 80-20 review. Imagine we're doing a fast-paced shift handoff. I will give you the patient presentation based on these high-yield textbook red flags, and I want you to give me the immediate nursing priority and the rationale.
I'm ready. Let's do the handoff.
Okay. Patient in room 4 was administered haloperidol a few hours ago. They are now presenting with a rigidly stiff neck, a thick protruding tongue, and severe muscle cramping.
That is acute dystonia. The priority action is to immediately administer an intramuscular anticholinergic like benztropine. We have to rapidly restore the dopamine-acetylcholine balance to secure their airway and stop the cramping.
Patient in room 6 is on a first-generation antipsychotic. They suddenly spiked a fever of 103, their muscles are locked in lead pipe rigidity, and their blood pressure is fluctuating wildly.
That's neuroleptic malignant syndrome. The priority action is to stop the antipsychotic medication immediately. Do not administer the next dose. We need to initiate rapid cooling and IV fluids to manage the autonomic instability.
We just initiated the patient in room 2 on fluoxetine for severe paralyzing depression. It is week 2 of treatment, and they are suddenly out of bed and pacing.
We're in the suicide paradox window. The priority action is unrelenting assessment for suicidal ideation and intent. Their physical energy has returned due to the rising serotonin, but the receptors haven't downregulated yet, meaning the profound psychological hopelessness is still present.
Patient in room 3 takes phenelzine and MAOI. They went out on a pass, ate aged salami, and drank a microbrewery beer. They're now complaining of a severe throbbing headache.
Hypertensive tyramine crisis. The tyramine is displacing their norepinephrine. The priority action is immediate assessment of their blood pressure and vital signs. This is a medical emergency with a high risk for hemorrhagic stroke.
Patient in room 5 has bipolar disorder and takes lithium. They have had the stomach flu for 3 days and are now presenting with severe diarrhea, vomiting, and profound muscle weakness.
Lithium toxicity. Dehydration has caused their kidneys to retain the drug. The priority action is to withhold the next dose immediately and draw blood for an urgent serum lithium level. Anything over 1.5 is toxic.
Patient in room 1 is prescribed Clozapine for treatment-resistant schizophrenia. They are complaining of a sudden sore throat and a low-grade fever.
High suspicion for a granulocytosis. The priority action is to hold the medication and assess their absolute neutrophil count immediately. The drug may have suppressed their bone marrow, leaving them defenseless against infection.
And finally, a patient prescribed lamotrigine for mood stabilization calls the clinic to say they noticed a new, blistering rash on their chest.
Immediate evaluation for Stevens-Johnson syndrome. The priority action is to instruct them to stop the medication and report to the emergency department, as this hypersensitivity reaction can quickly become life-threatening.
See, that is exactly how NCLEX logic works. The first nursing intervention almost always revolves around immediate physical safety, stopping the offending medication, administering the specific antidote, or assessing for a deadly side effect before it cascades into a crisis.
It forces you to recognize the exact moment a manageable side effect crosses the line into a systemic medical emergency.
Which brings us to the bigger picture. We've journeyed from the physical lobes of the brain down into the microscopic rivers of the synapse. We've seen how our pharmacologic interventions manipulate that environment, sometimes yielding life-saving clinical results and sometimes triggering life-threatening physiological risks.
But I want to leave you with a final evidence-based thought regarding the future of psychiatric nursing. We've spent this entire deep dive focusing on the brain, but the leading edge of psychiatric care is demanding we look at the entire body. The fields of psychoimmunology and metabolic screening are just exploding. We are seeing undeniable research linking systemic inflammation, gut microbiomes, and early microbial infections to the actual development of schizophrenia. Furthermore, we know definitively that second-generation antipsychotics cause massive metabolic syndrome,
creating a cascade of increased BMI, dangerously high blood sugar, and skyrocketing cholesterol.
Precisely, and recent meta-analyses show a disturbing trend. While the psychiatric field is getting better at checking the boxes for metabolic screening, the actual follow-up treatment for those physical conditions is consistently poor.
That's unfortunate.
It really is. So the provocative thought I want you to carry forward is this. The future of psychiatric nursing isn't just treating the mind. It is fiercely advocating for the whole body. How will you, as a future elite practitioner, integrate metabolic health, cardiovascular risks, and systemic inflammation into the daily care of a patient with severe, persistent mental illness? Because saving their mind while allowing their heart to fail is not comprehensive nursing care.
That is a powerful standard to set. As you head into your next pharmacology exam, or step onto the floor for your next clinical shift, remember to look past the muddy waters. You aren't just looking for broken bones. You are managing the complex, invisible chemical storms that make us who we are. Take this clinical judgment, trust your physiological assessments, and above all, keep your patients safe. We'll see you on the next deep dive.